Good afternoon, everyone. Welcome all of you joining the webinar hosted by the MFL Occupational Health Center. Today, the topic is about mandatory Covet vaccination for healthcare workers. The question is yes or no. So today we are so pleased to have Dr. Alan Kraut. He is the physician of the Occupational Health Center. We would like to begin by acknowledging that we are on the Treaty 1 territories. The traditional territories on the Assiniboine, Greek, OG Greek, Dakota, and Diné peoples, and the homelands of Métis Nation. We respect the treaties that we were made on these territories, and we acknowledge that we are all treaty people. At the Occupational Health Center, we commit ourselves to a process of reconciliation with Indigenous communities. So for the audience participation in this section, so to ask question, put your question on the chat section on the right side of your screen. The presenter will try to answer it after the presentation at the Q&A section. So you can also raise hand, by clicking the middle of the menu. The host will ask you to unmute yourself for your turn when you can ask. We may not able to answer all the questions in the Q&A. So please connect with us afterwards to follow up. And you notice that this session is being recorded for review later and share on the social media. And also please participate on the follow-up evaluation survey, giving us some feedback for upcoming events. So Occupational Health Center is a community health center established in 1983 and funded by the regional health authorities. We are currently located on 167 Sherbrooke Street. We provide services to the Manitoba workers with work-related health issues and work closely with the Joint Workplace Health and Safety Committee for training. So you can also book the appointment to see our physicians here and for any work-related health issues. And also we do not request for the referral, and it is free. We have the resource center here located at the center. And for information, then you can look it up. And please also visit our website for more information and resources. And please now join me to welcome Dr. Alan Kraut.
Okay. Am I sharing my screen?
Not yet. I haven't seen that yet. Yes, you are sharing the screen now.
Okay.
Thank you.
Okay, well, thank you. And it looks like we have a good large group here. So thank you all for attending and finding time in your afternoon to hear me speak on this topic. Before I start, I would just like to say that I do have positions with Shared Health, the Winnipeg Regional Health Authority, University of Manitoba, and the Occupational Health Center here, but that the views that I'm presenting are mine and should not be seen as reflecting those of any of the above mentioned organizations. So how big a problem is COVID for healthcare workers? We're hearing about it all the time in the news. Well, this is as of January, there was, I believe, over 65,000 cases in healthcare workers, and that represented 9.5% of all COVID cases in Canada were in healthcare workers. There were also 24 deaths in healthcare workers. In Manitoba, to January 15th, coincident with that slide, we had 1,742 healthcare workers who were infected with COVID. That was 6.6% of the total number. And by April, it had risen to 2,070 healthcare workers, but it would fall into 5.6% of the total. This is the epidemiologic curve of COVID in Manitoba. And you can see here, this was our first wave. And nowadays it sort of looks like a little bit of a wavelet last year in March. And then it was fairly quiet during the summer. And then it picked up in the fall, October, November, December, and then falling again into January, March, and now picking up again in April and May. And today was another not good day in the COVID front. I believe there were over 600 cases today. This is, again, this is from FIMS, so that's the provincial data that collects and records information. on COVID in Manitoba, amongst other things. And this is the number of healthcare workers. And again, you can see the first wave and up through the second wave, it was sort of similar there. It only goes to April 22nd, so we haven't seen the what's going to be after that. But there wasn't much of an increase here into early April, while in the general population, there was an increase. What about hazardous outcomes amongst healthcare workers? Well, again, this is for March 12th, 2020 to April 22nd, 2021. And to that time, there were 2,070 healthcare workers who had COVID. 652 of them, or 31.5%, were healthcare aides, 580 nurses, 28%, 77 physicians, 3.7%. To April, there were 2 deaths, both in healthcare workers, and unfortunately, recently we saw in the paper that there was a death of another healthcare worker, which brings it to 3. I should add that all of these cases aren't necessarily work-related. They're both community-acquired, unknown travel-required, and work-related, and this data can't separate out one from the other. There were 28 people who were hospitalized, and 6 ICU admissions. Severe outcomes are the combination of deaths and hospitalizations, and that there were 30. Of those, 43% were healthcare aides and 40% were nurses, which is a bit higher than their proportions of people who got sick. And very severe outcomes, which are deaths and ICU admissions, there were 8, 7 of which were healthcare aides. Now, healthcare aides have a number of non-occupational risk factors that probably put them in increased risk. I would bet they don't earn as much income as other healthcare workers, and they're probably living in more likely to be living in multi-generational homes, and they have other types of exposures. However, they're also the group that has the most contact with sick patients, suggesting that there might be an occupational component there. If we look at outbreaks, outbreaks are in our long-term care facilities and hospitals have been associated with a lot of cases of COVID. And amongst healthcare workers, 27% of the physicians were associated with hospital outbreaks. Nurses, about 26% with hospital, 28% with long-term care. The healthcare aides, 53% of them, or 346 individuals who got COVID, was associated with a long-term care outbreak, and 11% in hospital outbreaks. So again, healthcare aides seem to have an increased risk certainly of getting infected in long-term care facilities in the past. Now, in the WRHA, we have something called the RL system, where people who are concerned about COVID have to call in, and if they're not able to go to work because they're sick with COVID, they get recorded in the system. And I've been recording this data since November. The WRHA numbers are the number of new cases in Winnipeg in the prior week. The healthcare workers, or the number of healthcare workers that were diagnosed with COVID in the prior week, and then the percentage that is healthcare workers. And you can see in November we had 1,849 people in Winnipeg diagnosed with COVID, but almost 180 of them were healthcare workers. That worked out to be just under 10%. And then as the second wave rescinded, the numbers went going down, but the percentage of healthcare workers stayed between 8 and 10% then. Moving along, so just continuing here in late January, you can see the numbers in Winnipeg are going down, number of healthcares are going down, but generally the percentage of healthcare workers is continuing to, now it's around 4%, and then in April it starts getting into 2%, and the last one is 2.58%. You can see that we are now in May at high numbers, over 2,000 cases, which is more than we had before, but there's only 57 healthcare workers. So it's about, somewhere between a quarter and a third the number of healthcare workers getting infected now as in the peak of the second wave, and we're about 2.5% as opposed to almost 10% before. So at least in the healthcare worker work front, we seem to be doing a little bit better. So why might that be? Well, there's a couple of possible explanations. First of all, could it be that there is decreased exposure to infectious patients and clients? better compliance with IP&C guidelines or changes in PPE. We'll talk about that a little bit. What about vaccination program that started in December 2020? Or is it that the people who were most at risk already got infected, so there's a smaller pool of people who can get infected again? And we'll talk about each of those a little bit before we get into the mandatory vaccination part of the talk. Well, this is a slide that comes again from the FIMS data showing the number of people who are hospitalized. And here, this is our first wave here, not much over the summer, second wave. And then this goes to March 12th, and you can see how we'll start rising again. The dark green are the variants of concern, and the I guess the blue is regular COVID strains. And again, this has gone up in the last few days. So although there's, for a while, it looked like there were less people being hospitalized, now that's going up. And so it's not clearly that there's less people in hospital now. If you look at outbreaks, we have been doing a bit better from the outbreak front. In November and December, there was a lot of outbreaks that came down, January, February, March. And in April, the definition changed a little bit, making it be more conservative in calling an outbreak, and we don't have data for May. So these haven't gone up yet. During the second wave, there was a great emphasis placed on IP&C protocols and trying to make sure everyone was aware of what they should be doing and doing it according to how it should be done. And that may have, and there were some audits and may have led to some improvements in workplace practices. So that was one of the reasons why COVID seemed to be cut out of our personal care homes in February. The nurses union worked very hard to get increased access for N95 respirators for their members, and then Shared Health expanded that for basically all healthcare workers who are working with COVID suspect or positive patients. And you can see here, and this is a slide of how much N95s were used in the province each week, or at least left the facilities. And from January through March, the number in fact is going down, and the number of cases, percentage of positive healthcare workers from FIMS is also going down. So although the use of N95s may have been beneficial for some people, I don't think it explains the trend because they were both going down. It wasn't that more N95s were getting used. This is just continuing into May. There's a couple of high weeks of usage here, and that may have been related to other organizations requesting N95s. But again, you can see the trend is still a little bit down. We'll have to see what happens during the rest of May. The next possibility is, could it be related to vaccine? And I have to tell you, this is what I think it is. This is a slide from the first 2.5 months of vaccination. And this is the top line here is the number of people who had 1 dose. And then the darker part here is the number of people who had 2 doses of vaccine. And you can remember for the first couple of months, the only people getting vaccinated were residents of long-term care facilities, healthcare workers of varying definitions, and then people who lived in First Nations communities up north. So certainly vaccinating people in the long-term care homes would decrease the likelihood of outbreaks and indirectly protect the healthcare workers. And vaccinating healthcare workers obviously protects healthcare workers. And at that time, we were getting a second shot, and the rules changed shortly thereafter. Here you can see this is from May, and the increase in the number of people who have 1 vaccine, and not that much of a change in the people who had 2. Finally, there is the concept that if you get sick, that you'll have some natural immunity, and it has been shown in the first wave, this is data from Austria, that people were protected against getting sick a second time up to 7 months after their first infection. So in reality, it's probably a combination of all of those things that are leading to a decrease in the number of healthcare workers. But I think the one that's driving it the most, in my opinion, is vaccination. So the next question is, should we be making vaccination mandatory for healthcare workers? Well, We've got some mandatory vaccine policies in healthcare for, measles, mumps, rubella, varicella, pertussis, hepatitis B. One either has to be vaccinated or have proof of immunity for all of those conditions. For influenza, there have been some discussions and attempts in various locales to make the influenza vaccine mandatory. At first it was you either have to get vaccinated or wear a mask. There's been some pushback against those. In some areas it wasn't successful, and some areas it had been, and then they're changing their policies a little bit. So let's compare two diseases here, measles and influenza, one which we do have a mandatory vaccine policy in Manitoba now for healthcare workers, and influenza, which we don't. Well, they're both significant diseases. Measles prior to 1963 led to hundreds of thousands of cases in the United States, with many thousands of hospitalizations and people developing chronic disability, and almost 500 deaths per year. And influenza, it's estimated in Canada, we also have 12,000 hospital stays and 3,500 deaths. One of the big differences, though, between the two diseases is the vaccine effectiveness. Measles vaccine is said to be 97% effective after 2 doses. And unfortunately for the influenza vaccine, it's quite variable. It depends on the match year to year, and it can range from 10 to 60%. Also, with administration of the vaccines, it's, if we want to make it mandatory, it's a little bit easier for measles because there's 2 doses required in the childhood series. People get, when they enter training for healthcare professions, it's a requirement, so they get vaccinated then. And when they come to work, they get vaccinated. We have a requirement, and there's a few people that we still have to vaccinate. Influenza, on the other hand, is one requires a yearly vaccination, which makes it much more difficult to deal with. What about how infectious is the disease, both from patients to healthcare workers and healthcare workers to patients? Well, measles is one of the most infectious diseases known. It has an R0 of 10, which means that one infected person typically infects about 10 susceptible people. For influenza, it's also infectious, not quite as infectious. The R0 is 1.3. And there's been a lot of debate about how much vaccinating healthcare workers actually helps prevent disease in patients. And people that are opposed to it always bring out this Cochrane review that points out that, or states that there's not reasonable evidence to support the vaccination of healthcare workers prevents influenza in people over age 60. So this is part of the pushback against making it mandatory. Having said that, I still think getting vaccinated with influenza is a good thing. Well, what, if before you talk about making a vaccine mandatory, you have to talk about, well, why don't we try it voluntary? What are some of the things that increase influenza vaccination rates, and can we do those? And maybe we don't have to make something voluntary or make it mandatory. Sorry, well, there's a number of things that have been tried. The 2 most important is that the vaccine has to be free and it has to be convenient for people to get it. Other things such as champions and education, getting vaccinated in the past, support for leadership and rewards have all been shown to increase the vaccination rate a bit. Declination forms, where if you don't want to get vaccinated, you have to say that you understand the risks and don't want to, has also been shown to increase the rate of vaccination by about between 7 and 10%. However, what actually works the best is making it mandatory. This is a slide from a hospital in the States, where you can see their vaccination rate every year from 97 to 2007, and they're sort of going between the 40 and the low 50% rate. In 2007, they bring in a declination card and they get it up to 71%. And in 2008, they made it mandatory except for certain medical exemptions, and they're up to 98%. And some volunteer programs, I think, can get into the 80s. I haven't seen a volunteer program get into the 90s, and certainly not at 98%. So mandatory gets more people vaccinated. Well, why do healthcare workers get vaccinated or not get vaccinated? You know, we had an opportunity to study this issue with the H1N1 season, which is over a decade ago now. Wow. And we identified a group of healthcare workers that did not routinely get the vaccine, but did get the H1N1 vaccine. And we found in that group basically that there's a weighing of concerns against side effects, against concerns about the disease. And if people are more concerned about side effects, they tend not to get the vaccine. And those are more concerned about the disease tend to get vaccinated. There has been this is a study out of Montreal looking at vaccine acceptance, and just came out like last month. And it looked at almost 2,800 people who were invited to get vaccine, and they're all healthcare workers in a variety of institutions in Montreal. 72% of them were women, average age was 44, and just about 81% wanted to get the vaccine. They found that physicians, environmental service workers, and managers were more likely to accept vaccine than nurses. And they found that men and age over 50 and people who had occupational exposure were also more likely to get the vaccine. When they looked at people, so that was 81%, so the other 19% that didn't want to get vaccinated, they looked at why. And there was some reasons that came up. One was that people were concerned because the vaccine was new. They wanted to wait till other people got it, and they thought that there wasn't enough time to make a decision. And that about 3/4 of the people who said they didn't get it would possibly consider getting it in the future. But that left about 6% of people who were firm refusers and really didn't want to have anything to do with the vaccine. So when they compared them to the people who were a bit hesitant, they found that they were there had some major differences. The firm refusers were about twice as likely not to like needles or injections. They didn't trust experts. They didn't trust big farm. They thought the risks of the vaccine were better or greater than the benefits. They didn't think the vaccine was protective. They thought that they wanted to get sick first and thought that was better than getting vaccinated, which I must say is not a reasonable position. The risks of the disease, as we'll hear a bit later, are much greater than the risks of the vaccine. They thought that it wasn't a dangerous disease. We'll talk a little bit more of that. And then the last two, they had a bad reaction to vaccines in the past, or they had a contraindication, or they felt they had a contraindication to the vaccine. But a lot of these are attitudes and not so much can't really be addressed by education, which is one of our main tools to try to get people more vaccinated. And this study looked at 5,300 people in 24 countries, looking at their anti-vaccination attitudes. And I think if you look at some of the people that go to the anti-mask rallies, they have similar characteristics. These folks were high in conspiratorial thinking. They had a low tolerance for infringements in their freedoms. They had a high level of disgust toward bloods and needles. I'm not sure about that at the mass rallies. And they had strong individualistic views of the world, and had strong opinions about how much control society should have over individuals and whether hierarchies were in fact desirable. Demographic variables, including educations, really didn't amount for much of the variance here. So a lot of these types of things are really attitudinal, and it's would be difficult using an educational campaign to convince these people to get vaccinated. So when I think about people not getting vaccinated, I really divide it into three groups. The first is the unavailable. And these are people that would in fact get vaccinated if it was made convenient for them for a variety of reasons. They now with COVID, they can't go to the super centers where there's vaccination. They have family responsibilities, they have work responsibilities, and it just hasn't made it up their priority line high enough. But if they were, if the vaccine was brought to them, they'd probably get vaccinated. The second group are those that I would call the unsure. And these are people that really do have legitimate questions about vaccine efficacy and side effects. And I think if we concentrate on our efforts in talking to them and pointing out some of the data, they will get vaccinated with education. The third group, though, are the uninterested, and these are the vaccine skeptics, and they typically aren't moved by standard arguments. So they're probably a group that is not going to get vaccinated. So when, now we've talked a little bit about why people do and don't get vaccinated. So if we're looking for a vaccine and we want to decide, well, is it a candidate to be, is this a good vaccine to be a candidate to be made mandatory? We talked a little bit before about measles and influenza, and I pointed out some of the difficulties with influenza vaccine and making it mandatory. Well, what are some of the characteristics we should look for? Well, first of all, it should be very effective and safe. But also, the disease has to be associated with significant morbidity and mortality. It has to decrease the likelihood of transmission from patients to healthcare workers, if we're going to make it mandatory for healthcare workers, and reduce the likelihood of transmission of disease from healthcare workers to patients. So if something did all of these four things, then I think that that's something that we should consider whether it should be mandatory or not. And then there's some other hurdles to go through. So starting at the beginning. So are the vaccines effective? So this is a slide for BNT162b2 mRNA vaccine, also called the Pfizer vaccine. And this is a slide from the New England Journal when the study showing how it was effective came out. And basically, this is the number of people that got infected after they were vaccinated. And this is the number of people that got infected with placebo. And the vaccine itself was shown to be 95% effective in that study. In the real world, this is data from Israel, where they have a very strong vaccination campaign and in their general population. And again, they showed that the vaccine didn't stop all cases, but it was 96% effective in lowering the likelihood of getting disease, almost 95% effective in lowering asymptomatic disease, 98% in symptomatic disease. For hospitalizations, it lowered at 98%. Severe hospitalizations, like people who needed, I think, ICU and dialysis and needed to be intubated, it lowered at 98%. And deaths, again, over 98%. Although, again, the vaccine's not 100% effective, but it's pretty close and pretty good. And so that's good evidence that the vaccine is highly effective. This is also study information from that paper, and there's 3 lines here. So these are in people over age 65. The red line is the number of cases in the age group, and they had a lockdown in December. They brought in more restrictions in early January. And then here's when the vaccine rolled out. The light blue is people who had 1 dose, and then the dark blue is people who had 2 doses. And you can see as their vaccination rate went up, their level of disease went way down. And older people, 45 to 64-year-old group, similar, going down. In the 25 to 44 group, again, almost all disappearing. And you should note that in that age group, they had almost 80% of people who had 1 vaccine and almost 70% of people who had 2 vaccines. And then even in the 16 to 24 group, vaccination rates were a little bit lower, but again, the disease went way down and almost disappeared. So how does Canada compare? Well, I showed you a slide from Israel before. This is the red line is Israel, how it went up and up and up. And then with vaccination over a 3-month period, it went down to almost no cases now. The orange line is the United States, and our neighbors to the south weren't doing, or we were doing better from them in the first wave, and here into the second wave. and they were much worse than us. But look, by the third wave here, Canada's the black line. Now, unfortunately, we're worse than them. And in fact, if you compare all the states and provinces, I think Manitoba is the highest now in all the states and provinces in North America. So it looks like we have some more work to do. Well, the next question is, are the vaccines safe? Well, minor side effects are quite common, and it can be up to 15% in the second dose. It can be fever, fatigue, sore arm, muscle aches, but these are relatively minor and pass with time. The major concerns are allergic reactions to the mRNA vaccines, and that's the Pfizer and Moderna vaccines. And that happens in about 3.7 out of a million cases, or which means that 99.9996% of people who get these vaccines don't get anaphylaxis. There's been this CHAD-OX1N-CoV-19 vaccine, also called the AstraZeneca vaccine. There's been a lot of concern or talk about the issue of blood clots with them, and the number now quoted is around 1 in 100,000. But again, that vaccine, at that rate, it means that 99.999% of people don't have clots. So when the disease is fairly prominent and the disease is quite serious, this is not a significant risk against the great risk of the disease. Well, does COVID cause significant morbidity and mortality? This is from like a week ago now. And at that time, there was 1.29 million cases in Canada, over 24,000 deaths. Manitoba, I think we're over 46,000 cases now, which really is one in somewhere between 30 and 35 people in Manitoba have gotten COVID, and we're over 1,000 deaths. And that's like just over 1 in 2 dying from it. So it's quite a significant, serious disease. Well, can healthcare workers get COVID from patients? Again, this is a slide I showed you before, about almost 66,000 healthcare workers getting COVID in January, 24 deaths. If you look across the various provinces, you can see variable rates. Quebec was much higher than 14.3% because they had a lot of outbreaks. We were around sort of the middle, 6.8%. PI was 1.9%. Again, so I think healthcare workers can get COVID from patients. Can healthcare workers transmit COVID to patients? Well, this is data from Washington, the state of Washington, about a year ago. And this was one of the first personal care homes where there was an outbreak of COVID. And a staff member brought it in. 81 residents, 34 staff, 14 visitors got infected, and 23 people died from that outbreak. And they pointed out that there was limits in effective infection prevention and control measures, and that staff members were working in multiple facilities that led to the spread. So that was last year. What about this year? Well, this is a slide from personal care home in Kentucky, and here an unvaccinated healthcare worker or personnel brought it into the facility, got sick, and spread it. And these are all the people, the vaccinated healthcare workers, unvaccinated healthcare workers, and vaccinated residents and unvaccinated residents that got it. And there was a large number of them that got sick. When one compared the vaccination status of both the residents and the healthcare personnel that got sick, one can see that if you were not vaccinated, you were 3 times as likely to get infected if you were a resident, and almost 18 times as likely to die if you were a resident. For the healthcare personnel, if you're not vaccinated, you're 4 times as likely to get infected, and almost 8 times as likely to have a symptomatic infection. Fortunately, none of the healthcare personnel here were hospitalized or died. Can healthcare workers transmit COVID to patients? Well, we've had, just sort of anecdotally, we've had some home care clients who are living by themselves with no visitors or leaving their home getting COVID, and that's likely because the healthcare workers brought it in. Well, so I think, you know, if you look back at the criteria for making vaccine mandatory, is the vaccine effective? Yes. Is it safe? Yes. Is the disease serious? Yes. And can vaccinating healthcare workers lead to a decrease in the likelihood they transmit it to patients or they get it from patients? I think the answer to all of those questions is yes. Now, it's easy to say that. Now, the next problem is, what are some of the challenges that have to be addressed before you could implement such a policy? And is it worth the work and the hassle that might be involved in creating such a policy? Well, the first thing is that the vaccine has to be available. And currently, the vaccine is administered through the province of super sites. And as of today, it's not available in occupational health units. That may change in the future, who knows? But as of now, it's not that available. Healthcare, if we made it mandatory, healthcare workers would have to go to some site to get it, which would be difficult, and that's one of the reasons why some people don't do it. The next question is, well, there's a number of vaccines out there which should be made mandatory. I think that if we argue that we have to make one vaccine over the others when public health is basically saying that, you know, get the first vaccine that's available to you and that they're all effective, would be very counterproductive. So if there was a policy to make vaccine mandatory, I think we'd have to accept all vaccines. There'd be an issue of, do you make 1 dose mandatory or 2 doses mandatory? Again, that comes up with the availability of the vaccine. The third point is, if it's going to be mandatory, well, does your institution or program have the capacity to deliver? You know, some of the places I work with, I think that if we said, well, we're going to make this mandatory tomorrow, it would be very difficult to deliver that because of, you know, everybody's busy with what they're doing now. And there's, in fact, not the resources to make this mandatory at this point in time. Also, if an organization made it mandatory, one would have to accept that the side effects of the vaccine are a work-related condition. So that would mean that some time off from work for people who had side effects. And currently, I'm not sure how that's handled if they go get vaccinated and then don't feel well and go home. I think it comes off of your sick time. And another question to get addressed is, will voluntary vaccination be high enough to mitigate the need for mandatory vaccines? You know, the influenza data wasn't very encouraging, but the data I showed you from Montreal had 81% of people getting vaccinated, wanting to get vaccinated. So maybe if with education and making things available, we get a high enough number that we decide that maybe we don't need to make it mandatory. Well, you know, to find out what your vaccination rate is, you sort of have to know who's been vaccinated. And currently with the FIA, or Personal Health Information Act, employers can't sort of require people to tell them their vaccination status. My understanding is that they can ask, but that people aren't required to answer. So in Manitoba, currently, we don't know how many healthcare workers have been vaccinated. At the beginning, the first round, when it was primarily healthcare workers who were getting the vaccine, there were questions asking whether you worked in long-term or acute care. And then later, it was just whether you're a healthcare worker. And more recently, I believe that question has disappeared. The last time I asked, there were 51,000 people who reported that they were healthcare workers who had been vaccinated with at least 1 dose. But we don't have information by job title or institution at this time. Some personal care homes I've heard have asked, and I've heard numbers between 40 and 80% in those areas of the people who are vaccinated. Another organizational challenge that had to be addressed is, well, what about booster vaccines? Are we going to need to give a booster dose? Is that something that's going to happen? If you made it mandatory, would you require a booster dose? So, or do we just say, well, we'll make the first series mandatory and then require this later? And then you'd have to decide about what staff should be required for. Is it all staff who work in the institution, all patient contact staff that work in the institution, or just certain high-risk occupations and areas? Well, there's going to be some staff that can't get vaccinated, and who might they be? So according to NACI, certainly people who've had a severe allergic reaction should not be given the vaccine if they're allergic to any component to it. So those would be people that have to have a medical exemption from getting vaccinated. There's also some staff that need assessments according to NACI. So immunosuppressed people, people with autoimmune conditions, they also have pregnancy and breastfeeding. And because the vaccines weren't actually studied in those groups, the safety profiles haven't been clearly assessed. And at this time, NACI said that, well, you have to weigh the risks versus the benefits in all of these groups. And if you felt that the risks outweighed the benefits not to vaccinate, if the benefits outweighed the risks to vaccinate them, I would have to say that I'm not sure how many people who had these conditions who are working in frontline jobs with COVID patients would not want to get vaccinated. They're probably all not many of them aren't doing that now. But again, if someone had this and didn't want to get the vaccine, we would have to, I think we'd have to accept that. What about staff that decline for other reasons? Sort of, should there be religious or conscientious objections, and should they be allowed? So there's that has been accepted in other areas. I'm not clear on how one would define conscientious objections. And then we'd have to decide, well, what do you do with the staff who can't or won't get vaccinated? Do you just transfer them to another area? Do you send them home with pay, without pay? What would you do with those folks? So again, these are some of the decisions have to be made before one will consider making the program mandatory. And then there's some people that have said, well, I've worked with PPE for a year and haven't gotten sick, so why are you trying to force this vaccine on me now? Well, how would you respond to that kind of question? Well, here are some points. First of all, you have to point out that PPE is the lowest form of protection. Also, although good, there can be unnoticed breaches and it can fail in harried circumstances, and like things happen. And that's why it's basically the lowest form of protection. Vaccination is administrative control, which is higher up the hierarchy of protection, so that would make it more desirable. And finally, although we've all talked about PPE being the last line of defense, in reality, it's our immune system that's the last line of defense against COVID. And boosting that is an effective way to prevent getting sick or very sick from the disease. Finally, there's some legal issues, and I'm not a lawyer, so I'm not going to spend a lot of time talking about this and whether the disease became mandatory. But first of all, one would have to determine whether it's a bona fide occupational requirement, and I think I've given reasonable arguments to say that it might be, and versus personal autonomy, and whether that protecting patients and clients and coworkers sort of outweighed by the right to control with what one puts into their body. So I think that would be, something that would have to get assessed in the legal arena. Also, currently the vaccines are, I believe, under an interim order, but they're still widely used, and I expect them to get full approval shortly. So I don't think that that's a major problem here. And this was came out of an article in the Canadian Medical Association Journal. It was titled "Legal Issues, Mandatory Vaccination in Canada, Vaccinate or Stay at Home," published by these folks in February. And they pointed out that most of the case law was related to influenza vaccination and that it was labor arbitrations and not courts that decided that, so it's not as binding. They pointed out that influenza isn't COVID, and I would add that the COVID vaccines aren't the influenza vaccines. So again, the past decisions on influenza vaccination might not carry a lot of weight if COVID cases got to be challenged or were assessed. They felt that the provincial governments could set the rules. They thought that if vaccination doesn't prevent additional transmission over PPE, it may be unreasonable to make it mandatory. And although I think PPE is good for the fact that it's the lowest form of protection and can fail and for a variety of reasons, I think the vaccination would provide additional protection over using PPE. And currently, we're not saying that people who have been vaccinated don't have to wear PPE when they're dealing with COVID patients, and no change in PPE for them. They thought that if the Charter of Rights and Freedoms could be challenged, and that would be successful unless there were provisions for pre-existing health conditions and bona fide religious and conscientious objections. And finally, they supported no-fault vaccine coverage legislation. So they seem to argue that it might be reasonable to make it mandatory. But what about vaccine passports? And some countries do have passports, and the idea about vaccine passports is that people who show that they're vaccinated get to go to like sporting events and concerts and restaurants, and if you're not vaccinated, you don't. There was an article I read in the paper yesterday about Privacy Commission's approach to this in Canada, and they seem very hesitant to suggest that. So I'm not sure that's going to happen here. But the argument for this is, one, it encourages people to get vaccinated. Some people call that coercive, and other people say, well, maybe we have to coerce people to get it. If there's more rewards, then more people will get vaccinated. What about in Canada? Well, I mentioned what I heard and saw yesterday from the Privacy Commission, but for travel, I think it might be expected. The government's looking at this with some other countries, saying that if you're vaccinated, it might be easier for you to travel internationally. Certainly a number of countries have opened up their borders to fully vaccinated people. We don't have enough fully vaccinated people here yet to really consider doing that. But I think something is going to happen in this area. To go to Brazil now, you do need a yellow fever vaccine, so it's not that big a jump. Well, has anyone brought in mandatory vaccination policies? Well, a hospital in Jerusalem furloughed 80 people for not getting the COVID vaccine. And they have 6,500 employees, and they had a 93% vaccine uptake in their in their facility. But they brought in a policy to bar all unvaccinated workers from contact with patients unless they had an approved reason for not being vaccinated. They moved unvaccinated workers into jobs that didn't have contact with the public or putting them on unpaid leave, and would even consider terminating them. And they wrote this out to all their employees. The administration is obliged to inform each and every one of you that the administration can't provide the unvaccinated public with a working environment that's protected against the coronavirus, and that they won't provide legal defense or insurance if there was a lawsuit against a staffer who, by their decision not to get vaccinated, caused direct or indirect harm to anyone. So that's pretty tough. What about in Canada? Well, Sunnybrook Hospital in Toronto, as of the end of last month, had brought in a policy where either people had to be vaccinated, they had to provide an approved medical exemption, or they had to participate in a 15-minute module following a signed declination saying that they listened to everything and they're declining despite understanding the evidence. In Quebec, If you work in certain units, you're required to have proof of vaccination, such as the emergencies, and the medical intensive care, medical and surgical intensive care units, COVID clinics, units treating COVID patients, and long-term care facilities, and the lung units, the pulmonology units. And if you're not vaccinated, then you have to go for recurrent test screening to make sure you're not positive. And if you refuse to go in the screening, then they were going to reassign you to similar tasks in a sector not affected by the decree, so other wards, or if that's not possible, they could be put on leave without pay. So in the last few minutes here, I'm going to try to pull up a poll here. So we're going to get to see what the audience's attitudes are to infection, to this, whether it should be mandatory or not. So the options will be, what am I doing here? Okay, I'm going to have to show you the poll here. Okay, so Tiffany, can people see the poll?
No, let me do it.
Okay, you do it.
Yeah.
Okay, so the options are there should be mandatory vaccination with exemptions for medical reasons only, mandatory vaccination with exemptions for medical reasons and religious or conscientious reasons, voluntary vaccination with a mandatory declination form, voluntary vaccination with regular testing of non-vaccinated staff, and finally, voluntary vaccination, which we do now. So we'll give people a while to answer here, and we'll see what people think.
We will close the result when reach about 80% voted.
Okay, it's got a little bit more to go here.
Okay.
Just see when the numbers stop going up.
Mm-hmm.
So 70 of 98 now, so we're getting people moving. We're almost 76. And there's 20 undecideds. Okay, give it another 15 seconds and we'll stop then. Okay, so, oops, sharing the results now. Tiffany, you're sharing the results, right? Okay, well, about half people thought it should be mandatory with only exemptions for medical reasons. Another 12%, and the other ones are about all equal, thought it should be mandatory, and they allowed religious and conscientious objections. 12% wanted a declination form. Regular testing was 17%, and our current voluntary vaccination policy was only the preferred choice for 10% of people. Again, just, Tiffany, can you take a picture of that so we can save it for later?
Oh, I already closed, but
okay, I've got it on mine. I'm going to take a picture.
Sure.
Okay. Okay. So it seems that the majority of people, at least listening to this presentation, would be in favor of making it mandatory. Personally, I think that I like the idea of making it mandatory. I think that right now, you know, if a new employee came, we could give them, like we'd give them the measles vaccine if they needed it, but we can't give them the COVID vaccine, which in our current state is a little bit strange in my opinion. But I do think that there are a number of hurdles to pass before we get to this stage. Okay, so I've got a few minutes left. So,
okay, Dr. Kraut, I got the first question on the chat here. On the slide of the COVID-19 cases, who is included under all others? And
Well, it'll
some
be all
years
other healthcare work.
including dental or rehab or any others.
So basically, it would be all of allied health. It would be emergency room workers. I think dentists would also get included there in that group of all others.
Okay, another question is, are your cases of the healthcare worker comparison only for the WRHA or for all of Manitoba?
Okay, so the weekly comparison, the weekly numbers that I put up are for WRHA employees. The FIMS data, there was a period when I got data from them weekly, and then, you know, they've got like Stephanie, the woman that does this, I mean, she just gets pulled in 1,000 directions. So I wasn't getting it weekly from them, but the trend is quite similar for outside, you know, in the past for outside the province. Winnipeg has about 70% of the healthcare worker cases. But the similar declining trend was observed when I looked at the FIMS data, which would have everyone in it.
Another question is there a true infringement of human rights with mandatory vaccines, or is this perceived infringement?
Well, you know, I guess that's the argument that the people who are anti-vaccine would make and didn't want to make it positive, didn't want to get it, that, you know, it's their body and they have control over it, and how can people force them to get something? I think in my view, again, but I'm not a judge that'll judge this. I think the collective responsibility to society, if you're working with, you know, vulnerable people, you have a responsibility to do everything you can to protect them. And I think for the COVID vaccines, as opposed to the influenza vaccine, I don't think the evidence is strong enough to make influenza vaccine mandatory. I think it's a good idea and people should get vaccinated, but to raise it the notch to make it mandatory, I personally don't think the evidence is there. And I know some people will probably argue with me on that. But I do think if you're a healthcare worker and you're working with vulnerable people, some of them, even if they're vaccinated, you know, they have conditions that make them less likely to respond to the vaccine. We have a responsibility to protect them. So I think that we should have them vaccinated.
Mm-hmm. I got the questions here. Who should be a leading mandatory vaccine? Government, or it would be hard for a small personal care home site on their own? And yeah, Dr. Denise Colt and has put a comment here. The employers can implement mandatory vaccination, and currently Manitoba does not have any plans for implementing mandatory vaccination. Okay,
yeah. So I personally, I think it would be easier if the government said, you know, all healthcare facilities in Manitoba, we have to make it mandatory, and that their public health agency sort of comes out and says this. But I think that an individual, you know, personal care home, as Denise mentioned, could make it mandatory. And then if they were challenged by their healthcare unions, or that would have to work its way through the courts.
So another question is, what are the healthcare aide or medical doctor and the nurse's position number again?
I'm not.
What is the question? Can you explain it to us more?
Oh, the numbers. Well, the numbers that I presented were the number of, like, see, in FIMS data, what, you know, when someone is diagnosed, at least they ask them if they're a healthcare worker, and then they ask what job they had. So that's the numerator, the number of people that got infected. Unfortunately, for many professions, we don't have the denominator, or the number at risk. So we don't know, you know, for the healthcare aides, for example, you know, I think there were 600 and some odd that were infected. How many of them, that's 600 out of how many thousand healthcare aides are there in the province? So we don't know how many of them are at risk.
Another comment here is Texas Medical Center on Houston Methodist has implemented mandatory vaccine policy. They are started with incentives and now are about 89% of the 26,000 workers and will move to actually give notice come June. Will regularly bodies weigh in on ethical responsibilities of health professionals?
Okay. So I think that the comment there was that, you know, this hospital is starting, I guess it's moving to mandatory, and they're trying to get people voluntarily vaccinated. And I think at the end they felt that it was their, you know, the healthcare workers have an ethical obligation to get vaccinated.
Okay, I got another question is the COVID-19 vaccine not experimental for emergency use only or versus polio?
Right. So again, I did mention that it's it hasn't been officially sanctioned yet, and it is for emergency use. And I think that is a potential issue. I would imagine that in sometime in the not too distant future, the emergency use criteria will be removed. So I think that could be, so someone who's opposed to making it mandatory could certainly point out that argument. But and I think in the future it'll be, I expect, I mean, I don't sit on the committee that decides this, but I would expect with the growing evidence of how effective it is and the minimal side effects associated with it, that will become, you know, an approved vaccine.
So that's all for the question on the chat session.
Okay.
Thank you so much, Dr. Alan Kraut, and thank you all of you to participate in our webinar. We really appreciate your participation and putting some comment and good questions on the chat. So the session is already recorded. We are going to share on the social media and send you the link. You could watch it later, or even you could share with someone who missed the session. Dr. Kraut, someone that have been asked, you know, is the presentation slide will be shared?
I think this is all available. We'll talk about that. Okay.
Okay, sure. So last but not least, thank you all of you, and then hope you all have a wonderful Victoria Day long weekend, and then enjoy the time, you know, in your home to get enjoy some yard work if the weather is possible. Thank you so much. Okay, you guys all take care, stay well, and stay safe. Bye-bye.
Bye-bye.